Hello everyone, I'm Professor Deborah Bateson. I'm at the Faculty of Medicine and Health at the University of Sydney, and it's my absolute pleasure to be talking to you about these updated cervical screening guidelines in clinical practice. I'd like to acknowledge the traditional owners of the land on which I'm standing here today. So this is the land of the Gadigal people of the Eora Nation, and pay my respects to elders past, present and emerging. So these are today's learning outcomes to outline the upcoming and recent changes to the National Cervical Screening Guidelines, which are relevant to primary care, to discuss the rationale behind the test of cure following treatment for a high-grade squamous interepithelial lesion, I have to get my tongue around that, the HSIL, and testing options available, and to discuss the pathway for cervical screening after total hysterectomy, which is much more simplified, you'll be pleased to know. So these guidelines actually come into effect on the April the 14th of this year. They're actually available already. You can have a look at them and work your way around them. They're on this the web link that's shown here. You've got the QR code there. But as I say, the labs are really going to put them into effect on the 14th of April. And these are the summary of the changes that we're going to look at here today. So the guidelines have actually shifted to a new platform. It's called Magic App. It creates a more user-friendly experience. We've got a brand new chapter too, cervical screening in clinical practice, aimed specifically at primary care. GPs, nurses, the categories of people considered immune deficient have been clarified and expanded. And there's been changes to the post-treatment management for people who've been treated for a high-grade lesion. That's the test of cure pathway. Number 5, there's change in the recommendation for screening participants with HPV not 16-18 detected on a self-collected sample who, for a variety of reasons, don't come back in the recommended 6 weeks limit to have their cytology test to inform the risk and the next steps. But they don't come back until 9 months or more, and as we'll see, they can actually have an HPV test collected, which could be self-collected. Number 6 is screening after total hysterectomy, where it's indicated, and as I've said, this has been very much simplified. And number 7 is where there's changes to surveillance following treatment for adenocarcinoma in situ. So let's look at this Magic App platform. You might have heard of it because it houses other clinical guidelines as well, so you may be using it anyway. It's really got a fantastic structure to support ease of navigation for healthcare providers, and this is just a little bit of a snapshot about what it looks like. You can still access the guidelines through the existing Cancer Council Australia web link as well, and just make sure you bookmark it. Here it is as well as the QR code. And the key thing now is that this Magic App has layers of information, and it enables you to, it means they've designed it so you can actually, end users, that's us by the way, we can find exactly what we want, the most relevant information first, and then drill down to more and more deeper information if we want to. But it's all there at our fingertips. It's the things we really want to look at. So good practice statements, the recommendations and the decision flow charts are displayed on the front page of each chapter. And let's have a look at this new section. This came because it was asked for by GPs and nurses. They wanted something which brought everything together that you need to support your practice into one location. It also links to specific sections in the guidelines very easily, such as management of HPV test results, and it links to other resources in the National Cervical Screening Programme, including the really useful Healthcare Provider Toolkit. So great new design features. But let's now come to the changes and start with the change to screening for people with immune deficiency. And we're talking about immune deficiency, we're talking about groups with severe acquired or congenital immune deficiency deemed to have or be at substantially higher risk of cervical cancer and precancer and cancer. Now, most of the evidence actually references transplant patients and people living with HIV. But the advice on the other conditions has been extrapolated from these studies with immune deficiency experts helping guide this advice. Now, the key thing to remember, and this is not new, is that immune deficient participants assessed as being at substantially increased risk of cervical cancer should be screened every 3 years, not every 5, so we've got a reduced screening interval, and they should be referred to colposcopy by an experienced colposcopist or in a tertiary centre if HPV any type is detected, so that's 16-18 or non-16-18. So let's have a look at the categories. They've been clarified and expanded. And again, this list is not exhaustive. So 3-list screening is recommended for people living with HIV. It is recommended for solid organ transplant recipients on immunosuppressive therapy. I won't go through everything. People with primary immunodeficiency. And it should be highly considered. Now, this may be a decision made in collaboration with a specialist, but you are also the specialist in your own patient, so you can make that decision. And in fact, on the pathology form, you just need to be really clearly write that this person has got immune deficiency, because that, in fact, of course, impacts on the recommendations from the lab. And they won't know unless you tell them and write it down. So this should be highly considered in people, for instance, on long-term hemodialysis for more than 6 months, or long-term treatment for more than 6 months with highly immunosuppressive therapies. But let's now come to this significant change. This is the change to the test of cure following a high-grade treatment of a high-grade lesion, and have a bit of a refresher here. So what we do know is that the risk of recurrence and of invasive cervical cancer remains elevated for 10 to 25 years in people who've been treated for a high-grade lesion. That, as you all know, is either SIN2 or 3, so cervical intraepithelial neoplasia type 2 or 3. Post-treatment surveillance, we call it test of cure, is absolutely crucial to detect residual or recurrent disease. Now, the test of cure following treatment for a high-grade lesion involves annual testing until there's 2 negative tests, 1 year apart. They need to be consecutive before that person can be considered the back to baseline risk, and they can return to 5-yearly screening. So let's now come to this all-important change to the test of cure pathway following treatment for a high-grade squamous intraepithelial lesion. At the moment, until the 14th of April, I should say, the current recommendations are annual co-tests until there's 2 consecutive negative tests. So that means a negative HPV and LBC test. And if you remember, a co-test is where the lab performs these on the same sample, which means it has to be a clinician-collected sample from the cervix. It can't be a self-collected sample. Now, in the new guidelines coming into effect on the 14th of April, this has changed, because the test of cure now can actually be offered as a self-collected test. So a person could choose to have 2 consecutive, well, they could have annual HPV tests, which could be self-collected or clinician-collected, until 2 of these consecutive tests have got HPV not detected. So that's a really good thing. So don't forget, though, of course, when we're talking about HPV tests, if any oncogenic HPV type is detected, that person does have to come back to have that cytology test. But this is really great because, potentially a person could have 2 negative self-collected HPV tests, and then they've completed their test of cure. And this is what it shows in the flow chart. It's been updated, so you can see that someone's been treated for SIN2 or SIN3, and they have their HPV test. If they've got 2 consecutive negative HPV tests, either clinician or self-collected, then they return to routine screening. If they've got HPV 16 or 18 detected anywhere in that test of cure follow-up pathway, that is straight to colposcopy, as you know. But the one to concentrate is the one in the middle here. So this is where you've got an abnormal test of cure result with HPV not 16, 18 detected, where the LBC, the liquid-based cytology, is negative or possible or actual low-grade change. And in this situation, that person continues annual HPV testing until HPV is not detected at 2 consecutive tests. One new thing you need to know, though, if HPV not 16, 18 is detected with the LBC being negative or possible or actual low-grade change on 3 consecutive annual tests, then that person does need referral to colposcopy. So that's just an important piece of information to have a think about. Now, I want to come on to this really practical change that I talked about before, because we know that this can happen in many situations. So someone has a self-collected test, it comes up as HPV not 16, 18 detected. We know that in the recommendations they need to have a cytology test when they've got HPV not 16, 18 detected to determine the risk and further management. And that return for LBC is recommended within 6 weeks, or as soon as practical. We want to get people back as soon as practical. But what we do know is that for a variety of reasons, not everyone manages to get back in those 6 weeks. They may not come to you until 9 months or later. So for those who don't return until 9 months or later, after that HPV test with the not 16, 18 result, after the self-collected test, as we've said, what they can do then is actually not have a cytology test, so you don't need that. What you need to offer is an HPV test, and that's because this is going to potentially show that the HPV is actually cleared. So this is going to determine if the HPV infection has been cleared and the person can return to routine screening. It's a really great change, I have to say. And this is just showing it on the flowchart. So just a quick reminder again for those with HPV not 16-18 who don't return until 9 months or more after a self-collected HPV test, you can offer a follow-up self-collected HPV rather than LBC, and this is going to determine if the HPV has cleared. So let's actually just look at this within a case study. This is Samiha. She's 35. She's booked for her first ever CST. She is overdue for screening. Her results have returned with HPV not 16-18. You organise a follow-up appointment with her within 6 weeks, or as early as possible, but Samiha, for a variety of reasons, does not return for this follow-up appointment. She does return, though, for a contraceptive consultation 10 months later. You check on your records and you can see, oh, she didn't come back for that LBC. So what are we going to suggest? There's a couple of options here we can look at. Are you going to say, oh, we do need to take that liquid-based cytology, we do need that clinician-collected sample now, or are you going to suggest that Samiha could self-collect an HPV test again? And I'm sure you've all got the right answer for that, because absolutely now Samiha can self-collect an HPV test again. She's very happy with that. But now let's come to screening after hysterectomy. It has been very complicated and we have simplified it a lot. It's been simplified to annual testing, either a co-test or HPV test depending on the cervical pathology and the history, until there's 2 negative tests on 2 consecutive occasions. Now, this is what the old flowchart used to look like on the left, very confusing. This is what the sleek, new, simplified version looks like, and I'm going to take you through it step by step. So the key thing to know when you're looking at screening after hysterectomy, there's 2 vital bits of information. The first is what's that person's screening history? And it may not be known, of course, but that's going to inform the next steps. So what's their screening history and what's the pathology findings at hysterectomy? So these are the key things that are going to inform, as I say. So the majority of your patients are going to fall into one of these categories. And in fact, they're not going to need any further follow-up if they fall into these categories. So that's really, really a good thing for them. They'll be very pleased and you'll be very pleased. So no further follow-up is required if they, first of all, have no history of a high-grade change or adenocarcinoma in situ and no cervical pathology findings at hysterectomy. No need for any screening anymore. The second situation is where they've had a history of a high-grade change with a completed test of cure, which is all negative, of course, and no cervical pathology findings at hysterectomy. They're in the same situation and they don't need any more further follow-up. No more, they don't need vaginal vault testing after their hysterectomy. So these are going to be the majority of your patients, so that's very good to know. What about this group? This is a group where they need annual HPV testing. And again, it's those annual HPV tests until HPV has not been detected on 2 consecutive results. So which groups are these? So the first group on the left are the people with a past history of a high-grade change. They've had a test of cure complete, but they've got low-grade change or high-grade change pathology findings at hysterectomy. The second group are on the far right there. These are people, women who've had a past history of a high-grade change with a test of cure which is incomplete. So, and this is regardless of the pathology findings. So that's the next group. And then the group in the middle is one that can be, is quite common as well. So this is a person who's either never been screened or if they've got an unknown screening history. And again, regardless of pathology findings, they can have those annual HPV tests until they've had 2 consecutive negative tests. And let's come to this group. This is the adenocarcinoma in situ group. So they actually need annual co-tests. So don't forget this is the co-testing group because it's the adenocarcinoma in situ. So we just want to pay a particular attention here. And this is for people who've either had pathology findings of AIS at hysterectomy. You can see that group on the left and the group on the right. And they have annual co-tests until they've had 2 consecutive negative co-tests, or it's people who've actually had a past history of adenocarcinoma in situ and a hysterectomy. So, and testing can cease when those 2 co-tests are negative on 2 consecutive occasions. So we've dealt with people with hysterectomy. Let's just move on to this group now. This is the group who have been treated, had excisional treatment for adenocarcinoma in situ. And let's just remind ourselves around, do a bit of an AIS refresher. So AIS is an HPV-associated precancerous lesion of the glandular cells of the endocervix and the precursor to endocervical adenocarcinoma. Histological confirmation of AIS lesions often does occur as a result of a diagnostic excisional biopsy, usually a cold knife cone biopsy, which may or may not completely excise the lesion. And the current guidelines, up till the 14th of April, coming soon, require annual co-tests indefinitely. But we've had some new evidence that's come internationally. We've looked at our programme evidence as well, and so we've made some changes to this, which I'm going to take you through. This is the new updated flow chart for follow-up after excisional treatment for AIS. On the left, there's complete excision. On the right, there's incomplete, and they obviously need to go back for further excision to obtain clear margins. So let's have a look what happens here. So there's annual co-testing. Obviously, if there's any abnormal result in either of the co-test, either the HPV or the LBC result, then they have to go for colposcopy. So any abnormal result, go to colposcopy. But the key thing is, rather than having annual co-tests for the rest of your life, what we say now is what the recommendation is that interval can actually be extended to every 3 years if all co-tests have been negative for 5 years. So we're de-intensifying that follow-up. So I'm sure that many people, and clinicians will be very happy about this. And the other change is that if all tests have been negative for 25 years, then that person can return to routine screening if they're less than 70 or exit the programme if they're over 70. Now, I'm just going to spend a little bit of time on these colposcopy relevant changes. Obviously, none of us are colposcopists here, so I'm not going to go through all the detailed flow charts, but this is just so you're prepared, I suppose, if a recommendation comes back or the gynecology service recommends something that seems a little bit different, and this is what it's based on. So the key thing here is around the option to defer re-referral for those who've got HPV 16-18 detected, LBC cytology report, which is negative, and normal colposcopy, if the 12-month follow-up results are again HPV 16-18 detected and there's negative LBC. So that's important. It means that they can actually have a repeat HPV test in another 12 months rather than the immediate referral to colposcopy. The key thing, though, is that the labs should be still recommending that patients be referred to colposcopy. This is a deviation, if you like, that colposcopists can make. This is not for us to make. All the labs, this is for the colposcopists who wish to defer the return to colposcopy. They actually need to advise the NCSR, but it may just come your way. And this is just a complicated flowchart for colposcopists, and I'm just going to highlight this small part here. So this is where someone's had normal colposcopy. We call it a type 1 or 2 TZ. The colposcopist has been able to view the entire transformation zone. And then at that follow-up HPV test at 12 months, HPV 16-18 is detected. And then if the LBC, the cytology is performed prior to colposcopy, this is because it's been clinician collected and there's reflex cytology, then the HPV test could be repeated in another 12 months before re-referral to colposcopy. So they don't need that immediate colposcopy referral. So it's a particular situation, but useful for you all to know about. But let's come back to our cases now. So you remember Samiha here. She had her first ever cervical screening test when she was 35. She was overdue. Her results came back as HPV not 16-18 on self-collection. She didn't come back for the appointment at 6 weeks for a variety of reasons. And in fact, you don't see her until, if you remember, she came back for her contraception appointment at 10 months. And she is deciding what to do. So she, in fact, self-collected the HPV test again. But let's have a look at her now, because as I mentioned, she chose to self-collect at that 10-month follow-up. She was late for the 6 weeks one. She's over that 9-month demarcation line. And Samia's results again return HPV not 16. So what is her next step in this pathway? Should you advise that she returns to you for a cytology test and a clinician collected sample, or do we refer her directly for colposcopy? I'll give you a second to just think about what you might recommend. And the answer is actually you would refer her directly for colposcopy, and we'll have a look why that is, just to remind us really about the intermediate risk pathway. So Mia was overdue for over 2 years. It was her first screen, at her initial screen, and as this is a second HPV, not 16-18 result, she should be referred directly to colposcopy because she falls into one of the groups who are at higher risk of harbouring a high-grade change, even if the cytology is negative or low-grade. So this is the pathway. You'll all be familiar with it. It's the intermediate risk, well, it's a whole pathway. It's highlighting the intermediate risk pathway. And if you remember, so most people who have not 16 or an intermediate risk result, so not 16-18 with low grade or negative cytology, of course, everyone can have that follow-up at 12 months. And then the majority, if they have that same result again, so non-16-18 with low grade or negative cytology, they can actually have they can wait another 12 months, so they can have another repeat at 24 months since the initial cervical screening test, a second follow-up test before they're referred for colposcopy if it's persisting, if the non-16-18 types are persisting. But there's a group deemed at higher risk, or 3 groups rather, who we need to know about, because these groups, if it comes back with any oncogenic HPV detected, but obviously, if there's a repeat not 16-18 detected at that 12-month follow-up, then there's direct referral to colposcopy. And this is for people who are age 50 or more. It's for Aboriginal and Torres Strait Islander people, and it's those who are overdue for screening by at least 2 years at the initial screen. Now let's come to our second case, and let's meet Tori. Tori's 65, she's on long-term hemodialysis, and she's decided to self-collect her cervical screening test. And as per the updated guidelines, patients undergoing long-term hemodialysis should be highly considered for additional screening due to the increased risk of cancer. So you discuss this with her specialist, and collectively you both determine that she is at increased risk and she does need that more intensified screening. So how often should Tori undergo routine cervical screening? Is it every 5 years, every 3 years, or every year? I'm sure you've all got the correct answer, because it's every 3 years. And this just highlights that group. So obviously Tori's falling into that group where 3-yearly screening should be highly considered. Now, Tori's cervical screening test returns with HPV not 16-18 detected. So what is the next step for Tori? Is it immediate referral to colposcopy, or is it that she returns to you for a cytology test, a clinician-collected sample for liquid-based cytology? So have a think about that for a minute. Just remember the different guidelines for this group. And I'm sure you've all got this right, because it is actually the recommendation is for immediate referral to colposcopy. And this is because Tori's considered immune deficient, and she should be referred for colposcopy by an experienced colposcopy or in a tertiary centre if any oncogenic HPV, any type, I should say, is detected. So that's 16-18, or as in her case, not 16-18 types. There's no need for her to return for the clinician-collected sample for cytology, as this will be done at colposcopy. So that is the situation for Tori. And let's now meet Diana. So Diana is a new patient. She's 40 years old, and she had a total hysterectomy 7 years ago. She assumed this meant that she did not need any more cervical screening until she came to see you, and you've just read the updated guidelines. So you consult the National Cancer Screening Register, and you can see that Diana's actually had no screening history documented. You also know that Diana's hysterectomy found out that she had no cervical pathology. So what's the recommendation now for Diana? Is it that she has annual HPV tests, they can be clinician or self-collected, until HPV is not detected on 2 consecutive tests? Is it that she has annual co-tests, which need to be clinician-collected, as you know, until HPV is not detected on 2 consecutive tests? Or is it that no screening is required, as she's had a total hysterectomy with no cervical pathology found? And the correct answer here is that she can have those annual HPV tests, they could be clinician or self-collected, until HPV is not detected on 2 consecutive tests. So that's very good news for Diana. And this is just highlighting it in the flow chart here, just that particular scenario. So you've got all these to look at, and make sure that you understand them. They're much easier to use. And let's come to our last case study now, because this is Jenny. So Jenny's 45. She underwent a LETS procedure, that's a large loop excision of the transformation zone, for treatment of a high-grade squamous lesion 2 years ago. Now, she's already had actually a co-test, so her 12-month co-test, and that was actually negative. So if you remember, so in the current guidelines, which are going to change, the test of cure has been a 2 annual co-tests, which are negative 12 months apart. So she's had the first component of the test of cure, and both the HPV and LBC from that clinician-collected sample were negative. So what are Jenny's options now? Do you recommend a clinician-collected co-test, or do you recommend an HPV test, which can be either clinician-collected or self-collected? So let's have a look at the right answer. And the right answer in the updated guidelines is that now she can actually have the second component of the test of cure. Even though she's had a co-test, that's fine, that's all negative, we're happy with that. But now the second component just needs to be an HPV test, and that could be clinician collected with reflex cytology if there's any HPV detected, but obviously no cytology if it's HPV negative, or it could be self-collected HPV test. So she's very happy to hear about this new change as well, because she's very keen to do a self-collected test. So Jenny does choose self-collection, and her result is HPV not detected. So what is the next step for Jenny? Is it that she needs a follow-up co-test in 12 months' time? Is it that she needs a follow-up HPV test, either clinician-collected or self-collected, in 12 months' time? Or can she return to routine 5-yearly screening? I'll give you just a second to think about that one. I'm sure you're all thinking it through and will have the correct answer, which is indeed she can return to routine 5-yearly screening. So I've come to the end of the presentation with these case studies. I hope they've been helpful to put it into practice in your mind. What we would recommend is that you go and check out the new resource, which is available. It summarises the updated guidelines. Download your copy for the clinic and just work your way around them. You'll find it a really useful exercise. But if you do have any questions about the guidelines, do send an email to education@acpcc.org.au, or you can scan this QR code to send us an email. But thank you for your attention, and it's been wonderful to spend this time with you.